This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and how would you manage such a case? He's an 80-year-old gentleman who has pseudoexfoliation, non-dilating pupil, and hypermature cataract with a dense nucleus. And what should be our strategies to make the surgery very safe in such a patient? So let me take you through the things which are going in my head. See, my primary concern is about the zonular health in this patient. I'm not sure how the zonules would be, but as can be expected, the zonules would be weak because of pseudoexfoliation and as well as age and also the long-standing nature of the cataract. And the second aspect would be the nucleus itself would be relatively hard. So with this situation and scenario at hand, now how do we proceed with the surgery? So we should ask a couple of questions to ourselves now. Number one, what should be the mode of nucleus management? Should I do phacoemulsification or SICS? Now looking at the dense nature of the nucleus and also other coexisting complexities like the possible loose zonules, I would be preferring a manual small incision cataract surgery. And while doing manual small incision cataract surgery, what are the difficulties which I am going to anticipate? Number one would be the pupil. I need to deal with the pupil first. I need to use pupil expansion device, and because I'm doing SICS, it's always preferable to use hooks instead of a ring-based device because nucleus will be maneuvered out of the bag into the antechamber. So hooks are always a safe option. Number two, how do you deal with the weak zonules? Well, the idea here is to use a capsule tension ring to stabilize the bag. And the next question would be, what would be the time of insertion of CTR? Well, that would depend on the intraoperative scenario. If I find that the zonules are considerably weak, then I would insert the CTR much earlier, that is before the nucleus maneuvering. If the zonules are reasonably healthy, then I would withhold the insertion of CTR and maybe place it later on, maybe after cortex aspiration. So that would be purely an intraoperative decision. Number four, where would I place the lens? Now, in such a situation with generalized zonular weakness, which is progressive because of pseudoexfoliation, my preferred choice is the IOL trap technique, wherein I would be using a multi-piece hydrophobic lens with the haptics being in the sulcus and the optic pushed back and trapped in the rhexis margin. So that would give us a more stable lens for a reasonably longer duration of time. So these are the strategies which I have planned in my head. And in the worst case scenario, if I'm unable to save the bag, and that's also a distinct possibility because when I'm trying to maneuver the nucleus out of the bag, the entire bag can come along with the nucleus. That's an intracapsular extraction can happen inadvertently in eyes with loose zonules. So that possibility is also there. In the event of such a situation where I'm unable to save the bag, then I would be using the iris clip lens, which is posteriorly enclavated. So let's see how things turn out. Now, before I start the surgery, I would want to mark the two locations of the side port, which could come in handy if at all I would plan to use the iris claw lens, and I'd want to create an ideally situated side ports so that enclavation would be much more easier. After the conjunctival flap, I'm just using my 50 number blade to scrape off the episcleral tissue, that's the tenons. We all know that the bleeders are usually from the subconjunctival tissue, tenons, and if you can scrape it off, we can minimize the use of cautery because as we know, the sclera is a vascular structure. Conjunctival flap is created. I've created a small posterior groove which helps me to fixate the globe as I perform the sclerocorneal tunnel. The 7mm scleral incision is created about 1.5mm from the limbus. Using the crescent knife, the tunnel is being created. I prefer to do the tunneling in the left hand side and then the right hand side, and now we have a well-fashioned sclerocorneal tunnel which would be self-sealing. So I'm creating two side ports at the previously marked area. I'm keeping the intracorneal tunnel very short because it would be easier for me to manipulate the instruments for enclavation if the need arises. The capsule is stained. While staining, it's a little bit tricky here because once we dilate the pupil using hooks, there would remain some area which is not stained, and this is a mature cataract, so we really want the capsule to look good. So I am using just a few drops of trypan blue under the pupil so that it stains the capsule which is behind the undilated pupil as well. But mind you, have to be very careful not to use excessive amounts, because in these eyes with compromised zonules, it can seep across the zonules into the burger space, and that could be an issue later on. So be very mindful of that aspect, and when trying to wash it off, also press on the posterior lip so that the egress of the fluid is very easy and we don't build up any pressure in the antechamber, which could again force the fluid across the zonules into the burger space. I'm using dispersive OVD to pressurize the chamber. Now is the time to insert the hooks. In this case, I'm consciously using the capsule hooks to hook onto the pupil, not the traditional iris hook, simply because in the worst case scenario, if the zonules are significantly weak and I need to support the zonules as well, I plan to use the same hooks to support the capsule. Let's see how things turn out. So I'm making 2 additional ports, the one at around 6 o'clock and the second would be just behind my scleral incision. These are stab wounds, and the capsule hooks are then introduced one at a time, hook the pupil and then pulled. Now as you notice, I'm just engaging and not stretching the pupil up to the limbus at this stage, simply because I just want to wait until all the hooks are in place. And once all the hooks are in place, I'm going to now stretch on them so that the pupil becomes reasonably well dilated. Time to enter the antechamber through the sclerocorneal tunnel. Using a sharp 2.8mm keratome, the inner lip of the scleral tunnel is perforated and then it is extended laterally so that we have a wide inner lip which would allow the nucleus to be extracted out easily. Time to perform the rhexis, and I'm going to use the forceps. The moment I touch the capsule with the forceps, you can see wrinkles on the antisurface of the capsule, and also the entire lens back complex is moving around. So this is very clearly suggestive of a generalized zonulopathy with significant weakness in the zonules, and we're dealing with a loose bag. I switch my forceps with the needle. The needle being extremely sharp, we can perforate the capsule and raise a flap. Once the flap is raised, again I go back with my forceps and then try to fashion the rhexis. Now, what should be the size of rhexis? And that is very critical here. Now, if I want to use an IOL trap technique, I cannot use an extremely large rhexis. If I use anything around 6mm, I obviously cannot achieve my optic capture in the rhexis margin. So I need to be 5.5mm. At the same time, if the rhexis is very small, then there is always a chance of inducing or worsening the zonular weakness when you're trying to prolapse the nucleus out. So this is a fine balance which I need to strike here. I thought I've created a 5.5mm rhexis, and let us see how helpful it would be. Now, looking at the state of the health of the zonules, which was evidently quite poor, I decided to insert the CTR before nucleus management itself. So before that, I'm just trying to do some hydrodissection. The chamber is refilled with OVD, and then I'm going to use a CTR. In this case, I'm using a preloaded CTR. And this is marketed by the Madhu Instruments. It comes in 2 variants, the left side opening or the right side opening. In this situation, it is not really significant. We can use either the right side opening or the left side opening, since it's a generalized zonular weakness. The CTR is gently introduced under the anticapsule, and then finally the entire CTR is in the bag. I would want to go ahead and repeat hydrodissection just to ensure that the nucleus is truly free and mobile. We need to remember that during small incision cataract surgery, the maximum damage to the zonules will happen only when you're trying to prolapse the nucleus out of the bag. For me, it's imperative that the bag has to be stabilized before mobilizing the nucleus out. So the CTR is in, repeated the hydrodissection, the nucleus appears to be fairly free, and now is the time to use 2 Sinskey hooks to gently wheel out the nucleus out of the bag. See, bimanual maneuvering of the nucleus is an art which has to be learnt and mastered by every surgeon who is doing manual submersion cataract surgery, because in such tricky situations, it really does help. Let me play this in slow motion. I've got 2 Sinskey hooks. My right hand is pushing the nucleus away towards the right hand side, and the left Sinskey hook goes in and tries to hook the equator. And as you can see, rhexis trying to get involved, and the bag is also trying to come out along with the nucleus. So I retract the rhexis margin with my left Sinskey hook and eventually elevate the nucleus away from the plane of the rhexis, and then the entire large nucleus could be wheeled out of the bag into the antechamber. and hopefully without damaging much of the zonules. This is exactly the reason why we need to introduce the CTR early, which would help us to provide 360 degrees support to the bag, which can bear the stress when you're trying to maneuver the nucleus out. Under the cover of OVD, using the phaco sandwich technique, that is, the Sinskuk is on top of the nucleus and the vect is under it, the nucleus is gently expressed out. I'm just using irrigation to flush out all the free lens matter. Now, to perform the cortex aspiration, I may need to make another additional port here. Created that, and very slowly but surely, every bit of cortex is gently peeled out. I need to remember that we can lose the bag even at this stage. When you're trying to maneuver the cortex out, you have to be very patient and slow. That's the only secret. At some point, I get a doubt that probably is there a vitreous disturbance, so I go back and inject diluted triamcinolone acetate just to check on it, and thankfully there's no prolapse vitreous. I'm feeling that there's a lot of positive pressure. It is primarily because of the fluid which is going across the zonules into the burger space and causing some sort of a fluid misdirection that is causing this sort of a positive pressure. Well, that is to be expected in such eyes with generalized zonular weakness. So we need to be mindful that the things can go wrong at any stage of the surgery. So we need to maintain that high level of concentration at every step. So time to implant the lens. I'm using a cohesive OVD to create some space and maintain the space in between the iris and the capsular bag. The multi-piece lens is injected with the leading haptic going into the sulcus. Then the trailing haptic is gently dialed in. Now time to remove the hooks. They're disengaged from the pupil and gently maneuvered out of the eye. Now, before I achieve optic capture, it's important to remove all the OVD which is behind the lens. Once it is done, with the irrigation in my left hand, the optic is nudged back so that it goes behind the rhexis. In this case, the one half of the haptic is behind the rhexis margin, the other haptic is not. So I'm just trying to maneuver the other edge of the optic also behind the rhexis margin. Now it seems that both the edges of the optics are within the bag and the haptics are in the sulcus. You can see a small lens particle in the burger space moving around. Well, this is clinical sign which is proof of the fact that there was a free access of fluid across the zonules. So everything which was there in the antechamber had access to the burger space that is posterior to the posterior capsule. This is a common scenario which we see in eyes with generalized zonal laxity. The barrier effect of the zonules is very less, and in fact the antechamber can have communication with the chamber behind the lens as well. Again, before closing, diluted triamcinolone acetate is used to ensure that there is no prolapsed vitreous. All the ports are hydrated. The conjunctival flap is then closed with glue, and that's it, the case is done. So finally, we were successful in saving the bag, and all the plans which we had in our head eventually were implemented well enough, and the outcome were decent. These were the first day post-op picture. The vision was 6/18. There is some amount of corneal edema. It would settle over a period of time. We can see the sphincter tears. That was because the pupil was rigid and I had to have good exposure. That's the reason why we had to stretch the pupil a bit more than what I would have liked. But nevertheless, these are the small price which we have to pay to eventually get a good outcome. To summarize, I think to have a good outcome in such complex cases, planning is critical. In this case, the pupil were dealt with by using hooks, which provided us a good view, and the timing of the CTR insertion was appropriate so that we prevented any exacerbation of the zonular weakness during the maneuvering the nucleus out of the bag. And finally, we could achieve a good optic capture with the haptics in the sulcus so that the IOL trap would work well and provide a long-term stability of the lens in this particular eye. That was it. Thank you for watching and hope you found this helpful.